Hi, I'm Deborah Siegel. I'm a hematologist and clinician scientist at the University of Ottawa, and I was the principal investigator on the STRATUS trial. It's my pleasure to walk you through some of the background details of STRATUS, including some lessons that we learned along the way. So I've selected a few aspects of clinical trial design and implementation and analysis to discuss with you today. We'll start with trial intent and the research question. You may recall that the rationale for the STRATUS trial was that blood sampling contributes significantly to anemia and red blood cell transfusion in patients in the intensive care unit, and that 90% of blood collected for testing is discarded as waste, which means there's an opportunity to reduce blood loss without compromising patient care. Lower volume tubes are actually available, compatible, and have the same cost, and we reasoned that a randomized controlled trial with clinical outcomes was needed to change practice. So our research question is, or was, in adult intensive care units, does transition from standard volume to small volume blood collection tubes reduce red blood cell transfusion? So it was important for us to select the optimal trial design to be able to answer our research question definitively. And in reflecting on the optimal design, we were often asked this question, why are lower volume tubes not already used? And certainly an element of this was that there was an evidence gap. There were no randomized trials addressing this issue or small volume tubes, which meant that there was uncertainty about benefits and harms. And so there was an established rationale or equipoise to conduct a randomized trial, but there were also important barriers to implementation, including concerns primarily from the laboratory medicine community about the potential for problems with sampling, testing, and result reporting. There were concerns about an impact on laboratory process, such as validation of lab tests with the small volume tubes. There was also a lack of awareness in general about the availability of these tubes, their compatibility, how they worked, and their cost. And then finally, there was a sense of complacency or a desire to maintain the status quo. So if something isn't broken, then why fix it? So based on the feedback that we received from stakeholders and concerns particularly around implementation, we conducted the STRATUS pilot study to directly assess feasibility of implementation of small volume tubes in order to inform whether the STRATUS full-scale trial would be feasible. We conducted a before-after, so standard volume versus small volume tube observational study in the cardiovascular ICU in Hamilton. We piloted some educational resources, including presentations and videos, and we also conducted focus groups to understand the user experience. And the primary outcome here was feasibility, which was defined as a successful switch, so whether or not we could actually implement the tubes, whether people would use them, adherence, the proportion of insufficient samples, and if there was a signal for harm here. We assessed user acceptance. We tried to identify barriers and facilitators of implementation. And finally, we piloted our data collection processes. After 10 focus group discussions with ICU nurses and lab technicians, we found that the switch to small volume blood collection tubes was acceptable to end users. And you can see here from some of the comments that it was easy to incorporate into practice. There weren't any significant barriers, just being able to visualize the queue of how much blood you need to fill into the tubes. There was the education and training sessions were helpful, and there was any anticipated problems with implementation. So we determined STRATUS to be feasible based on 100% adherence with implementation, a high acceptability to end users. We did not see a signal for increased insufficient samples, which is of course the concern with the use of smaller volume tubes. We noted a 45% reduction in estimated blood collected and determined that the full-scale trial would be feasible. So in considering further what type of design to use, we reflected on this framework, with the explanatory versus pragmatic trials. And of course, there is a spectrum of explanatory versus pragmatic, but thinking about explanatory trial as one which answers the question of whether an intervention can work under ideal conditions, or a pragmatic trial which answers the question of whether an intervention works under usual conditions. So I can say that our initial iterations of study design included an individual participant randomized trial in which patients admitted to the ICU would be assigned a tube volume, either small volume or standard volume, and it became quickly clear to us based on discussions with experts and stakeholders that this would just not be feasible in the complex environment of the ICU, and that there was major concerns about contamination and noise that would really impair our ability to detect a difference between groups. So we abandoned the idea of an individual participant randomized trial and proceeded to think about a more pragmatic trial design like a cluster trial. And in fact, we selected the stepped wedge cluster randomized trial for STRATUS. Like other cluster randomized trials, stepped wedge designs involved the randomization of a unit of care. In this case, it was the ICU. And this is the type of design which is frequently used for the introduction of a new policy or treatment, particularly one that has a high likelihood of benefit and low likelihood of harm. The intervention is introduced in timed steps at which one or more sites receive the intervention, but the timing of the switch is randomized such that eventually all the sites have the intervention, which is shown in the diagram on the right. And the reason that it's called a step wedge trial is you can see the diagram looks like a wedge with steps in it. So I think you can appreciate how this seemed like an optimal design for the STRATUS trial because this type of design can assess both effectiveness and implementation with this dual focus. So you can test the effects of a clinical intervention on relevant outcomes, and here it's small volume tubes, impact on red blood cell transfusion, and also we can implement a likely effective therapy into clinical practice. The advantages are that this is a randomized design, but importantly, each cluster is exposed to both control and intervention states, and that means that we gain back some of the power lost due to clustering compared with some other cluster trial designs. We can obtain information for both researchers and policymakers, and this means that there's a potential to improve the speed of translation of research findings into practice. So we'll talk a little bit about implementation now. And really, from conducting the STRATUS pilot study, we recognized just how important site outreach is or was to the conduct and successful completion of the full-scale STRATUS trial. Again, this is an intervention that's embedded within routine care, so the people who are conducting the study essentially are nurses and lab techs doing that as part of their routine jobs. It was really important for us to ensure that those teams felt engaged, felt supported, and had the resources they needed to ensure successful implementation and maintenance of the intervention over time. We visited all of the sites. We provided educational opportunities with rounds, other presentations, discussions at the bedside. We engaged nursing educators and senior lab technicians to nominate champions at their site to help others learn about the tubes and some of the differences that they might experience. We provided resources such as the one is shown here, which is a poster that was customized for each site according to the tubes that they used. And we also provided swag, which was customized pens to help people feel engaged and motivated to continue to participate. Next, we'll just touch briefly on some of the statistical concerns. We estimated the sample size for the STRATUS trial using estimates for the parameters listed in the table from published literature, including an average duration of admission of 5 days, proportion of patients receiving transfusion of 40%, an average transfusion of 2 red blood cell units per patient per ICU admission, and an intra-class correlation coefficient of 0.01. Using these estimates, we determined that 18,240 patients distributed across 25 ICUs would be required to have 90% power to detect a 2.5% relative reduction in the primary outcome. So from 2 to 1.95 red blood cell units per patient per ICU admission. And I think it's shown in the table below, but the actual estimates were quite different than our initial estimates. Certainly, at the end of the STRATUS trial, we ended up with a much larger sample size, 21,000 patients in the primary analysis population and 27,000 patients in the secondary analysis population. And really, it was only in the secondary analysis population that we detected a statistically significant reduction in red blood cell units transfused, suggesting that we had less statistical power to detect this difference between the groups than we did initially. And I think this is reflected in some of the differences in the estimates that you see in the table. But the takeaway message from this is that it's really important to ensure robust estimates of key parameters for sample size estimation, as this is really what will determine whether or not there is statistical power to be able to detect a difference if there is one. And you want to be able to be sure that you can have a definitive trial that's adequately powered. So I'll speak briefly about the COVID pandemic disruption and mitigation. As you recall, transitions were delayed at 7 sites between March and August of 2020, but the sites still used the tubes that were allocated and data collection continued. However, there was a lot of uncertainty about how the results would be affected, particularly because the ICUs were so affected by the COVID pandemic, and we were concerned about the possibility of bias in the results. So we made the difficult decision to amend the primary analysis to remove patients admitted during early COVID due to the anticipated differences in the types of patients that were admitted to ICU and also the care that was provided. However, we did do an analysis of all the patients admitted for 48 hours or longer as our key secondary analysis. And I think it's important to recognize that extenuating circumstances can happen, and this is from the Conserve 2021 statement, which is a guideline for reporting of trials that were modified due to COVID or other extenuating circumstances, acknowledging that these things can happen, and in a way, to expect the unexpected, or at least be able to report what was done and how the changes were made, so that readers can understand the rationale for the changes that were done. I think for the STRATUS trial, retrospective vision is 2020, and if we could go back, I would recommend that in the face of extenuating circumstances, it's really important to seek outside counsel and really carefully consider all options. For example, in the STRATUS trial, we elected to remove over 6,000 patients from our primary analysis population, and as it turns out, based on our analyses afterwards, there did not seem to be an impact of the COVID-19 pandemic, nor were there any period effects detected. So in the end, it appears that there was less of an effect of the COVID-19 pandemic on our trial, at least on the results, than we had anticipated. And perhaps there would have been other ways for us to manage or mitigate the effect of the COVID-19 pandemic in our trial that wouldn't have involved removing a substantial proportion of patients from our primary analysis. There were some important ethical considerations in developing STRATUS. We obtained a waiver of individual participant consent from research ethics boards to conduct the trial because the intervention was applied at the level of the healthcare environment, and that both tubes fell within the standard of care and are used clinically. So this was deemed to be appropriate for a waiver of consent, minimal risk to patients, that the waiver would not adversely affect patients' rights and welfare, and also that it would be impractical to carry out the research if consent was required. But importantly, we did provide information to patients and families with the option to withdraw data, and you may recall that one patient requested removal of their data, which we did. We had a lot of support for STRATUS, including many collaborators. And it's very important to remember that relationships are key to successful trials. And I always say about STRATUS and other trials that it takes a village to raise a trial, and it is certainly the case. So you really need to nurture those relationships when conducting any trial, but particularly a pragmatic trial, again, embedded in routine practice where people doing their daily jobs really were the ones who ensured that this trial was a success. We had a large team, including trialists and statisticians, hematologists, intensivists, hospital administrators, industry, not with financial support, but with logistical support. Laboratory medicine was key, and then finally nursing. I think the one team member that's missing here is a patient or caregiver who can speak to the patient importance of the trial and ensure that it's being done in a patient-oriented way. And so although we didn't have a patient representative on our STRATUS team now on all my trials, we do have patient or caregiver or people with lived experience who inform the design, the conduct, and interpretation of the results, and then dissemination of the results as well. So here you can see just how many people were involved, and this actually doesn't even include all of the nurses and lab techs who kind of made it happen on the ground. And finally, we'll just touch on data aspect. We used electronic data collection exclusively. This was a very pragmatic approach, but it meant that we had 25 individual data sets, which were combined into one data set, a massive data set, which ended up being about 450 million data points. So I think the message here is don't underestimate the time and cost needed to set up and analyze databases. This is really important, and we were fortunate to have biometric support, biometric programmer support, but something that should be considered a priority to anticipate and avoid problems later on. And just as we approach the end of the discussion, I just wanted to mention the importance of knowledge translation. And perhaps knowledge translation is something that we typically think about at the end of the trial when we're trying to disseminate the findings of our trial and integrate into clinical practice. But really, I think we should be integrating knowledge translation right from the beginning at the design stage as the trial is ongoing, and then of course at the end. I was fortunate to be involved in the rapid practice guideline, which recommended the use of small volume blood collection tubes over conventional blood collection tubes in adult ICUs. This was a strong recommendation based on moderate certainty evidence and primarily influenced by the STRATUS findings. So with that, I'd like to thank you for your attention and the opportunity to talk to you today.